actually, your answer to Mr. Pugh on the 7-day NHS issue. We got to the fact that it's all included somehow in the 10 billion that was approved by the Chancellor. Ballpark, how much of that 10 billion is needed for the 7-day NHS?
We haven't separated it out in that way, because part of what we're trying to achieve through a 7-day service is very much at the heart of what we're trying to do in terms of new models of care, the way in which we're looking at different...
So, for example, if you didn't do the 7-day contracts that are potentially being imposed, I'm just interested in how much you think you would save by not doing it. You must have an idea of what the number would be.
So can I just be clear, in terms of the junior doctors' contracts that you're talking about, that we're...
I suppose it's not just junior doctors, is it? No, okay.
Well, for the junior doctors' contracts, we're not changing the overall envelope of pay, or the amount we pay for junior doctors in terms of those contracts.
No, but if they're working more weekends, presumably there's somebody else who's having to cover, if you've got the same number of doctors, shifts and rotas and rosters that they're not doing in the week.
Well, so it's important to look at the whole of the contractual environment in terms of thinking about that. Clearly, there's been an awful lot of attention over the last few months around
I don't want to spend too long on it, but I just wanted to understand. You said the 10 billion covers the 7-day NHS. I just wanted to know, and you've told me, I think, the answer.
Yes, it is.
There isn't a... But
there is no separate pot that we've set aside for something with the specific label of 7 days.
Doesn't give a great feeling of warmth that you understand the implications of the policy in terms of manpower. I mean, another way of asking the question is, what is the delta in manpower that you need, man and women power that you need in order to meet the 7-day NHS there must be an implication.
Well, I wish it was a question that could be answered in a simple way, in a mechanical way that applied to every single trust and local health economy.
Right. But if you don't know the answer for the whole NHS approximately, I understand you have to work it through in detail, but if you don't know in broad terms what that answer is, I mean, how can you be doing the policy?
Well, it differs so substantially from one local health economy to another. When we've looked at some of the 8 adopted... the 8 adopted trusts that we've looked at, some of those have talked about that driving cost savings. A lot of those talking about the reduction in bed days that happens as a result of that, and without leading to additional cost in terms of the deployment of their senior clinical decision
makers. Yes, but you're the guys that are sitting above all of these trusts, and you've already given evidence that if all the trusts were as good as the best trusts, the world would be a better place and everything like that. I'm just kind of surprised that you can put this policy into place without having some idea of the implication for staffing levels at the headcount planning level, which is what today's hearing's about, or indeed cost and budget.
So that's a big part of the reason why the planning guidance in December asked local footprints to create their own sustainable transformation plans that brought together all of those issues.
So what if the answer comes back as being more than £10 billion then?
Great. On your data, what you know about the workforce, there is no readily accessible data on vacancy rate. There's limited data on course completion rates. There's limited data on leaver rates, and there's no inclusion of information on staff employed by agency for temporary staff. So you don't know, do you?
So the report rightly identifies that there are some data gaps within our workforce planning.
That's generous.
I wouldn't disagree with that. That isn't to say there isn't action that we're taking across the system to fill those data gaps. We have a workforce information architecture process where we are essentially coming to plans for specifically how we're going to plug those gaps, and that feeds into the workforce advisory board that Professor Cumming chairs, that looks at the workforce planning across the system to deliver 7-day services and the 5-year forward view. So we have work in train. We don't yet have that data, and I agree that is something that we need, but I would hope that the next time we have this conversation, we would be looking at that from a very different perspective.
I have to say the lack of data, as Karen Smith has rightly highlighted, really worried us before the hearing, and I'm not sure that we're convinced by the answers that you can do your job without that data. But I'm going to bring Chris Evans in for a quick fire, and I've got a few more points in the last
Just a quick piece of information. I've just had a news text here that says the BMA have announced a further 3 days for industrial action. How is the 10-day service going to work in light of this, especially with junior doctors leaving?
Well, obviously that news has come in since we've been sat here today. Clearly, the position we've got to where we are introducing a new contract is not one that we were aiming to achieve. The reason we brought David Dalton in to lead the negotiating team was with a very clear and genuine objective to reach a negotiated conclusion. David Dalton led a process with a range of chief executives across the service who said that they thought the contract that had been developed, that David Dalton had developed, was a fair and reasonable contract. And they also said that it was important that there was certainty for the service moving forward. And that is why the Secretary of State made the decision that he did to introduce a new contract. It is a highly regrettable consequence that there is more industrial action, as you say. Every day of industrial action where elective care is withdrawn is a day where there are 3,000 or more fewer planned appointments kept with patients, and clearly we all need to be very anxious about the degree to which that affects patient safety.
I say this in the House of Commons a number of times and on the media, but given you've acknowledged you don't have the data, and you freely acknowledge that, it is interesting that the Secretary of State and the department went out and imposed a contract on junior doctors when there are real gaps in your long-term planning for staffing.
Well,
seems like you're flying blind.
Well, we believe that the contract that we are imposing is a better and safer and more reasonable contract than the one that currently is in place. It means that doctors that could now be working up to 91 hours a week.
My point is you don't have the data to really understand the impacts of the decisions at the centre. I mean, you've acknowledged that, and we've heard some of the concerns about that lack of data coming through in evidence today.
And that's part of the reason that we asked David Dalton to lead that negotiation process.
But he didn't have the data either.
Well, working with a range of chief executives, I think one of the themes of the conversation this afternoon has been that this is both a question of judgment as well as one of scientific fact. And actually, the range of chief executives that David Dalton was engaging with through that period are ones who I take very seriously what they've been saying.
We won't go further down that because I'm just aware of time, and in the last couple of minutes I just wanted to ask a couple of particular questions. First of all,